This program is brought to you by Emory University.
Good morning, everybody. Thank you for tuning in this morning to Fellows Conference. Our speaker this morning is Dr. Errol Inci. Errol is one of our second-year fellows in the clinical track. He went to the University of Florida for undergraduate, then the University of Central Florida for medical school, and then out to St. Louis to Washington University for his residency. And he is currently applying for interventional cardiology and is going to talk to us today about coronary artery aneurysms. Dr. Inci.
All right. Thanks everyone for joining. Hope everybody had a good Thanksgiving. Thanks for tuning in. For those of you who don't know me, I'm Errol. We're going to be talking about coronary artery aneurysms. Let's kick into it. Our objectives today, we're going to explore the history of coronary artery aneurysms, define what really makes a coronary artery aneurysm and significance. And we're really going to try to navigate the therapeutic options available in today's world. So first really described in 1961 by Morgani, the famous Italian pathologist and anatomist, who made his career based on autopsies in a time where we were really doing many. He briefly first mentions coronary dilation and study of a diseased aorta in a syphilitic patient. Didn't really elaborate beyond that. Didn't seem like it was tied to the patient's cause of death. Not really till 1812, Charles Bouillon, the French chair of clinical surgery, described the case in detail of a French revolutionary soldier. This soldier, 42-year-old French revolutionary soldier, he had this kind of unspecific rheumatic condition, which he had been dealing with for years. Started to begin with symptoms, progressive anginal symptoms. The symptoms were interestingly improved by leeches, and they were worsened with phlebotomy. The veteran soldier, after several years of dealing with these symptoms, witnessed to have severe sudden chest pain, followed quickly by a sudden death. On autopsy, discovered that he had severe dilation of a proximal portion of his right coronary artery. There it had been clearly ruptured and was filled with a blood-filled pericardium. Looking back in this, more suggestive of why these therapies may have worked is as we know, leeches have an inherent anticoagulant similar to heparin, which can last in their body, potentially helping. And phlebotomy, as we know, in our anginal patients with coronary disease, when they're anemic, they can have worsened symptoms. Of course, Bouillon didn't last too much longer in France. He was quickly exiled out with Charles X. His PubMed bibliography coincidentally kind of cut off after that. Moving into the 20th century, by 1953, this case presented here, still only routinely reported in case reports. Although we had now at this point had advances in microscopic evaluation, we were able to see different histological findings. Possibly not even different layers of the coronary vascular tissue were affected. The demographic of these patients could still continue to puzzle physicians, in that they range from the very young adults to teenagers to children, even to the very elderly. In this case right here, we have Trinidad presented a LAD aneurysm of a 59-year-old patient. As we can see on the under the microscope, there's a nice thrombus right in the middle of there. Wasn't really described by angiography until 1958 by Troel Munkner of Denmark. He demonstrated the first angiographic coronary artery aneurysm in a 6-year-old boy with Kawasaki disease. Some would still say you can see this camera in cath lab too. So moving in, what is a coronary artery aneurysm under this umbrella of coronary artery dilations? It's a focal dilation of the coronary artery segment of at least 1.5 times the adjacent normal segment. And here are two cases side by side in which I think we can all agree the right side, it's very easy to say that area is dilated. Even by eyeballing, you can say it's about 1.5 at least times bigger. But on the left side, it's a little harder. There's coronary disease in there. You're not quite sure what is your reference vessel in that case. In these scenarios, there's not a ton of guidance on what to do as far as their definition. A lot of trials, what they do is they'll take 1.5 times bigger than the mean age and sex for matched patients. It has to be differentiated, and they're very often interchanged within the literature. and even when we're talking about coronary artery dilations, is coronary ectasias. And that is the same, and that is 1.5 times bigger than the adjacent normal segment, but it's involving more than 1/3 of the coronary artery length. It is important to distinguish. I'll elaborate a little bit on that a little bit later. And then we go into our more subclassifications: coronary pseudoaneurysms, saccular fusiform, and of course the giant coronary aneurysms. Pseudoaneurysms, as we know, is a loss of that vessel wall integrity, which is not damaging all 3 layers with intact intima or media. And here we are seeing a IVUS performed, and you can see those 3 layers: the adventitia, the media, and intima. And here the intima is preserved with disruption in that medial layer. And below that is a nice pseudoaneurysm in the proximal LAD portion. Saccular aneurysms. This is a nice case of a 51-year-old lady who had been coming with some more heart failure symptoms, and they found this saccular aneurysm, and that's where the transverse diameter is exceeding the longitudinal diameter. And that's going to be in opposition to the fusiform aneurysm, which the longitudinal diameter exceeds that of the transverse diameter. This is the case actually that kind of got me interested in this topic. It was Kathleen's person with Dr. Jabber. This was a 35-year-old patient who had end-stage renal disease, HIV, Hep B, hypertension, prior endocarditis, plenty of reasons to have coronary artery dilations, which we'll get into. Giant coronary aneurysms, the really scary ones. This is where the definitions are a little bit looser. Per the pediatric definition, which there is a little bit more guidance and data on, this is where a focal point of the vessel is greater than 8 millimeters in diameter. The adult literature, as I said, though, that can really vary in the cutoff. In the literature, you can see somewhere between 8 and 20 millimeters being that cutoff for them calling it. Typically, more in the adult range. A lot of times literature will define it as a large being a little over 8 to 10, and a giant being somewhere in around a 15 to 20. It's a nice bowling ball that Jeff South made and gave me in the left main. Pretty impressive. Into the prevalence, just to quickly kind of talk about it. Heavily debated. There's a lot of different trials out there, both small and large, talking about the incidence of this. The 3 of the larger ones, the CAST trial in 1987 reported a whopping 4.9%. Of note, they didn't differentiate between aneurysms and ectasia. Since that time, and one of the critiques of this is that since that time, small or large studies have not reported any incidence above 2.5%. Nunez et al. In 2017 probably described the largest case series with 51,000 angiograms reviewed and reported about 0.8% incidence. That was backed up by Luo et al. From China, which had a similar occurrence. Really inconclusive evidence on the preference of sex. Some slight more suggestions that possibly more likely in males. However, age, diabetes, hypertension, kidney disease, dialysis, all of these can be implicated in the development of aneurysms, but not really specific to it. Interestingly, though, that study out of China, Luo et al., where he had not excluded ectatic patients, he differentiated them, found coronary artery disease with atherosclerosis risk factors, hyperlipidemia, smoking, atherosclerotic disease, more prominent in the coronary artery aneurysm group compared to that of the normal and the ectatic groups, maybe suggesting that this isn't one similar disease with 2 presentations, but more possibly it's 2 different pathogenesis planned in 2 different presentations. And then a point that I'm really hoping to drive home this lecture, and you'll hear me repeat it again, is that the correlation of atherosclerotic coronary disease and its relationship to these coronary aneurysms. In this study in Luo et al., he makes a remark that almost all of these aneurysms were in the area of either a pre-stenotic or post-stenotic lesion, potentially contributing to the aneurysm formation. We're jumping into the etiologies. Been suggested that there's many different etiologies connected to this disease state. There's been genetic associations There's several suggested. One I thought was fairly interesting was the 9p21.3 allele, strongly associated with aortic and intracranial aneurysms, possibly related to coronary aneurysms as well. It's linked to a proliferative phenotype that promotes adverse vascular modeling. In the literature, suggested approximately 10 to 20% of these aneurysms felt to be congenital. And the argument for genetic predisposition is that I'm going to tell you about a lot more different types of etiologies that we see in our general population, but not everybody, in fact, the majority do not develop any kind of aneurysm formation. Atherosclerotic disease, thought to really account for almost up to 50% of coronary artery aneurysm cases. This is where you'll see this under histological examination, hyalinization and lipid deposition, leading to disturbance of those intimal and medial layers of the vessel, destroying its muscular elastic components. Ultimately, that pressure in the vessel is unable to eventually tolerate it, and that's predisposing to subsequent dilation and aneurysm formation. That's a separate topic in its own, is the inflammatory state that has been well described at this point in atherosclerotic disease, which is thought to largely contribute to eventual degradation of the vessel and aneurysm formation itself. Here I'm showing some slides, A and B up top, just trying, if you can see on the very far left there, you can see some of those very large lipid crystals. Then focused in on slide B, you can see those some inflammatory changes in there. And the bottom ones showing that on that C, just a little thin wisp of that black elastin remaining, as well as D, they're losing smooth muscle in that tunica media area. You can't mention coronary artery aneurysms without talking about Kawasaki disease and the vasculitis pathologies. To quickly review, because I know it's been quite a while for some of us since we've been in the pediatric world, predominantly affecting children less than 5 years of age. It is now currently the most common cause of acquired heart disease in children in developed countries. Most prominent and described in the Japanese population. However, at this point, it's been described in all ethnicities, described worldwide. And it's really defined by that rapid, very severe inflammatory process of the medium-sized vessels. The most consequential outcomes being involved in the coronary arteries. That's marked by, going back, we had that bilateral conjunctivitis without exudate, marked by fever, that's cervical lymphadenopathy, that strawberry tongue, that erythema and edema of the hands, and that, of course, that rash, macular papular diffuse erythrodermic rash. Going into some more of the pathology of how these aneurysms form with Kawasaki, we can really see they can kind of go one of three ways. The first two being that there's really no coronary artery changes at all, period. They're not affected. Sometimes we see a very mild transient dilation that resolves after 1 to 2 months. IVIG, if promptly treated, can really help out with this. And then where we get into trouble is really when we get into our necrotizing arteritis. This can kind of lead to one of two ways. And one, there's that subacute chronic vasculitis after our aneurysm formation. The vessel walls breaking down. You start developing these non-occlusive thrombus. And then more towards the bottom end of there, that thrombus gets calcified, possibly leading to stenosis in those areas. And then there's a more acute presentation, which is the scary one. You never want to see a child in this scenario where they have that occlusive thrombus formation, area infarcts, eventually leading down the same pathway. So we can see multi-vessel coronary aneurysms in these patients that have been well described, even peripheral aneurysms. Here we have a nice MRI case. You can see, looking in that RCA aneurysm territory, you can see a nice aneurysm there with thrombus formation around it. Up on top, there's that left main giant coronary artery aneurysm. And then just to highlight some of the peripheral aneurysms that can form, in this case, we can see some maxillary and subclavian arteries being affected. Really miraculous recovery of IVIG has dramatically decreased the incidence of aneurysms in Kawasaki patients from 25% to just under 4% worldwide. Just some honorable mentions that have been described in literature. Takayasu, lupus, polyarteritis nodosa, rheumatoid arthritis, all things to think about. Moving into our connective tissue disorders, Ehlers-Danlos, wide range of genetic mutations affecting collagen. Me and Dr. Wells were just talking about this yesterday. And each one can have its own different kind of presentation. Marfan's disease, as we maybe remember from medical school, affects that fibrillin-1 gene. Here's an MRI on the left showing what we classically think of with its association with aortic aneurysms. More rare, but neurofibromatosis, fibromuscular dysplasia, all have been associated with coronary aneurysms as well. Then getting into our iatrogenic causes of coronary artery aneurysms. Of course, this group would never admit it. They'll deny it, even upside down Brian there. But the statistics show that these guys have long careers ahead of them. And if you're a betting man, they may be sending a coronary artery aneurysm your way sometime in the near future. Hopefully not too near. And that's thought to be due to local wall injury, just from that sheer force of that angioplasty, coronary dissections, brachytherapy, or intracoronary radiation, which is used sometimes as adjunctive therapy, especially when you're reintervening on a lesion, and the type of stent placed. Drug-eluting stents, biodegradable stents. The drug-eluting stents, really, it became kind of prominent concern with the first generation. It's been less described with third generation stents, but really unclear if that's more of a reporting bias versus a true improvement. That really remains unknown. And then an alarming increasing number of reports from these biodegradable stents as well. Ju et al. Showed a study here in which he just looked at 5,600 patients who underwent PCI and then followed them afterwards. 78 of these patients developed coronary artery aneurysms. These were with first generation stents. Followed these patients over 5 years and had a whopping 26.9% increase in major adverse cardiac events compared to those who did not develop coronary artery aneurysms. Mainly, these events were secondary to stent thrombosis and in-stent restenosis. And we can see here, this is a case, you can see in that proximal RCA lesion with that arrow's pointing, some stenosis there. They angioplasted it, caused a dissection. Everyone's probably panicking in that room. They put another stent in there. All high fives around, it's disappeared. Nobody's got to know about it. I think we swept it under the rug. Patient comes back 8 years later, now with a large RCA STEMI, either showing a pseudoaneurysm with a little bit of thrombus formation in there. They open that area up, but there we have it, a nice pseudoaneurysm. There's been a lot of infectious suggestions in literature. One case that I found particularly pretty interesting that will probably give most interventionalists nightmares, and why you may see them pretty hesitant to do it with anyone who's even have a whiff of infection. Singh et al. Described the case in 2005 of a 56-year-old male. Described pretty classic anginal symptoms. As you can see in that proximal LAD area, there is some tightening over there, believed to be significant, presented with the ACS picture. So they went in, they stented that area, first generation drug-eluting stent. Everybody felt good about it, sent him on home. Unfortunately, patient returns 4 days later. He's febrile, found to have MSA bacteremia. They felt to be due from the procedure. They do an echocardiogram on him, no vegetations, feel pretty good about it. They send him home on some antibiotics for 4 weeks. Patient's doing okay. Once he stops antibiotics, though, fevers start coming back, and then subsequently, a couple days later, presents with a very large anterior MI. And then they take him back to the cath lab, and they find these very large saccular aneurysms in the proximal LAD at the area of that stent, believed to be from mycotic aneurysms. This patient in particular immediately rushed back to surgery for an aneurysm resection. So the clinical presentation, we've already kind of talked about some of them. Of course, the majority ischemia, myocardial infarction, but we always have to appreciate that the majority of these coronary aneurysms are likely clinically silent, only incidentally found on angiography or CT. And the outcomes, whether they've been treated or not treated, are primarily based on patients that have had asymptomatic coronary artery aneurysms, and really only included in these studies once they're presenting with some kind of ACS picture. Other presentations can be more of a mass effect. And in the worst scenario, thankfully very rare, is aneurysm rupture, which quickly leads to tamponade and almost surely death. Manihol et al. Followed 1,300, a little over 1,300 Kawasaki patients in 1990 to 2007. He stratified them based on small aneurysms, less than 8, or large aneurysms, greater than 8. And interestingly, their coronary artery events, the small aneurysms, really only 1% over the length of the study had any kind of event, opposed to the large aneurysms, which had a dramatic increase in their events. Talking about ischemia, something that's every coronary aneurysm case, I think, will be discussed kind of back and forth and does take some thinking, is that are patients presenting from symptomatic coronary aneurysms, or is there some underlying coronary disease? Kruger et al. Performed a nice study, 67 patients looking at different areas. He did use ectatic patients as well, but isolated aneurysm patients here. And what he did is he took him back to the cath lab and he started pacing them. 3 minutes each at 100, 120, 140, 160. And he actually drew lactates from their coronary sinus while he was monitoring their symptoms. This graph's a little bit confusing. As you see, it's going more negative. It's trending upwards. So in this case, a more negative cardiac metabolism, lactate metabolism percentage is correlating with more lactate production, whereas it gets more positive, that's less lactate production. And that group 1 with the triangles up there, those are correlating with bilateral aneurysms with a diameter greater than 2 times the reference vessel. 2, kind of get in that middle range, is when we're having bilateral ectatic vessels, then non-significant bilateral coronary ectasia is kind of in the group that didn't really have much lactate production. Another separate topic on its own, the topic of microvascular dysfunction, not to belabor it too much, but has been shown also to be relevant in these coronary artery aneurysms as well, using these blush grade methods, really showing how the microvascular dysfunction can be present, even in the face of TIMI3 flow within the macrovascular vessels. Once again, hammering the point of its association with atherosclerotic obstructive coronary disease. This obstructive disease, to remind everyone, it can be just plain atherosclerotic disease, can be layered chronic thrombus, severe calcification. Amoka et al. Started using more invasive hemodynamic studies with intravascular coronary Dopplers to look at the diastolic to systolic velocity ratios, coronary flow reserve. He found a moderate decline within the actual lumen of the large coronary aneurysms when they were isolated by themselves. Not really dramatic declines, though, interestingly, in the pre or post areas without any coronary disease. But what he found is that you add any small amount of stenosis, even mild stenosis, less than 25%, you start suddenly seeing significant declines in their flow reserve, as well as their diastolic to systolic velocity ratios. Murakami further backed this up using FFR among 47 patients with isolated giant aneurysms. And he suggested that there's mild drops in the aneurysms, however, nothing too serious, but when there was aneurysms in series or series with a stenotic lesion, that you start seeing some drops in their FFR. And then to also hammer home the point here is what is the risk of this? Doi et al. Showed a study where he observed these patients for 49 months with either ectatic or aneurysmal disease plus obstructive disease on top of that, showing significant increases in their major adverse cardiac events. 4.94 hazard ratio. Baman et al. Supported that by isolating just coronary aneurysms by themselves, describing a higher elevator risk of events happening. As we know, thrombus formation with myocardial infarction, here we can see a very threatening proximal LAD thrombus, which is just threatening to cause a pretty massive infarct. Our very own Dr. Kumar et al. From back in his days when he was still at Mayo, describe cases that's a known clinical entity in this mass effect. Here we see a very large right coronary aneurysm, just absolutely crushing that right atrium, affecting the RV, causing more of an SVC type syndrome picture, lower extremity edema, orthopnea, and facial edema. This patient eventually progressed to surgery. Courtesy of Dr. Douglas, fascinating case here of a saphenous vein graft aneurysm. This was a 78-year-old who had a CABG about 13 years prior. This patient presented with a mediastinal mass that was being worked up. Here's a reconstituted CT of that, presenting similar with that SVC type syndrome picture. It's a rare entity that's really only been described. There's 147 cases described between 1982 and 2008, but its mortality is very significant, death rate of 14% within 4 months of the diagnosis. Getting to our imaging assessment. Predominantly described in angiography, although we're seeing a lot more with CT nowadays. But angiography is actually not a great way to study these aneurysms. You have delayed antegrade contrast filling, partial backflow, contrast stasis, really suboptimal imaging of not only the aneurysm, but of the coronary vasculature itself. IVUS has been shown to be very helpful to help delineate structures where you're dealing with true or pseudo aneurysm, can help with there's a formation of thrombus, both chronic or acute, as well as really helping to size a vessel. It's been decided to intervene on that, finding these landing targets of this vessel, sizing your stent is more important than ever. And CT, to some point, MRI emerging really as a cornerstone for assessing these cases, allowing for very accurate evaluation of the aneurysm size, shape, as well as presence of degree of thrombus and calcification. And the benefit of this, of course, is without the risk of actually doing a procedure. So getting into the management now, the barriers we have to understand to reinforce here. We don't really know the natural history of progression of this disease. It's largely unknown. That's because a lot of these will remain asymptomatic and they're not really discovered until their incidence is discovered. Even the optimal, and then to that point, the optimal treatment is really unknown. There's not really trials looking at asymptomatic coronary aneurysms and what to do with these patients. For the patients, even with where we've concluded that the aneurysm is it's contributing to some symptoms with the patient, it's a very technically difficult procedure, whether you're going a percutaneous method or a surgical method. So there's a lot of hesitancy to continue with those or go forward with those. And really just a large lack of large scale data. We're cardiologists, we're used to these thousands, 10,000s, looking at aspirin versus DAPT, et cetera, where we just don't have that kind of data with this patient subset. So to kind of hit into some points just on medical management, these are going to follow in that even though the evidence is Class B and Class C evidence, we don't have a lot in adult populations. Thankfully, though, with the high prevalence of Kawasaki disease patients, they have a little bit more guidelines. They see this a little bit more structured on what to do with these patients. And so kind of some more low-hanging fruit, things that you can think about with your patients with a coronary aneurysm and really attack aggressively. Trying medications that can easily be stopped if there's some kind of adverse event without any real serious consequence. Hopefully, I've impressed upon you at this point the importance of atherosclerotic disease and coronary aneurysms, not only in the etiology of these aneurysms, but also as a compounding coronary insult on patients with aneurysms. So very aggressive medical management, hypertension, diabetes, very aggressive lipid control, more important than our standard population. From the Kawasaki guidelines, things that make sense, avoidance of NSAIDs. This is thought to be through involvement with our interference with our COX pathways, especially when we're starting aspirin on these patients. And things that we sometimes don't think about as we're dealing with a more elderly population that may be postmenopausal, or things that we can do to decrease risk of thrombosis. Can this patient, are they on an estrogen birth control pill? And a progesterone or a low or estrogen agent can be used alternatively, thinking things along those lines. ACE inhibitors, not a lot of strong evidence, but the angiotensin II has been linked with an inflammatory response, thought to more predisposed to these coronary aneurysms. Interestingly, these last two, vasodilators, long-acting nitrates, something that we think of as in our forefront when we're dealing with someone with obstructive coronary disease, has been shown that it can actually sometimes in certain scenarios harm patients. Kruger et al. In that study where he had paced these patients, he also gave them nitroglycerin. Not only did he see that they didn't have resolution of symptoms, sometimes worsening of symptoms, but they also had increased lactates. That's thought to be that you're dealing with an already dilated vessel, but you may be causing excessive dilation. Now, of course, I think you take this with a grain of salt. I mean, I think you shouldn't shy away from potentially trialing. And the cases I reviewed within our own system, case reports, some of these patients see relief with nitrate therapy. And that kind of goes to is the symptom really from the aneurysm or is it from the coronary disease? There's other factors with nitroglycerin, or you're decreasing the preload, et cetera. So I think to really keep in mind with that is that if you start a patient on a nitrate with an aneurysm and they have worsening pains, to be pretty prompt to just pull that off and keep that in mind. Beta blockers, not really suggestive evidence with aneurysms, but the guidelines, especially in the Kawasaki guidelines, do recommend it in the face of large or giant aneurysms to be considered. And that's based on more our data showing the absolute benefits with obstructive disease, especially in those with ACS, despite what their LV is doing. All right, so to kind of get to where you're going to see in the clinic. So, you know, this is a classic scenario. ER got a CTPE because they don't have to explain why. They found this coronary artery aneurysm. Call the on-call fellow. Fellow says, if the trope don't fit, you must acquit. Refers to outpatient clinic. So you put on something a little casual there. Sit in your chair, start reviewing the case. You know this patient needs some form of probably aspirin, Plavix, warfarin. So what do? There's not really a cookie cutter guideline here. There's no cookie cutter case. Yet we know the most incriminating evidence that you can find for a truly symptomatic coronary aneurysm is that of thrombus formation. And it's very important to treat these patients to try to prevent that. And so scenarios that you may see the person who's just been freshly stented. Here we see a proximal LAD stent, some mild aneurysmal disease. Maybe you see the patient that I had presented earlier, that 35-year-old with a whole laundry list of reasons why you could have a coronary aneurysm with that very large LAD, some thrombus formation in there. You may see the patient like this, 59-year-old, history of CAD in 2015 at an outside hospital. We're already seeing aneurysms here. We're not seeing any thrombus formation really, but we're seeing aneurysms throughout the entire vessel. That proximal LAD area that's showing like a mid D1 occlusion, the RCA area, ectatic vessel with a mid aneurysm. Started on aspirin at this time, now coming back 4 years later, 50% perfusion defect, complaining angina, that D1, the microvasculature is totally obliterated. We're seeing a mid-LAD CTO now, and IVUS that's showing a very large proximal LAD aneurysm here. And what do you do with these patients? You know, that we've seen progression of disease at this point. You escalate them. And I think it really, you have to analyze each case individually. There's possibly no other field in medicine that prescribes more anticoagulation, antiplatelet agents than we do. We're inherently trained to be constantly vigilant. High-risk patients who are anticoagulation constantly need to be reassessing for bleeding risk, and kind of sizing them up for if they can tolerate, what agents they can tolerate. I think assessing the size of the aneurysm, very important to do. Is there a presence of thrombus? Maybe a little bit more straightforward, that those patients should be treated more aggressively. And is there the presence of obstructive disease? Is there a progression of obstructive disease? Do we think that obstructive disease is from overlying thrombus that's contributing from the aneurysm? So jumping into the aspirin, the aspirin P2Y12 inhibitors, there's not really a ton out there. The Kawasaki guidelines are helpful here. Those guidelines stay in that low dose aspirin as monotherapy is more than sufficient for prophylaxis if you have a small coronary aneurysm. For the P2Y12 inhibitors, they state that if you have moderate disease, this is more so to just escalate therapy without putting your money down on full anticoagulation. And that's more so based on what we've seen with obstructive disease with the pulse. Ju et al., interestingly, in that study we had described earlier, this is the study where they had PCI, developed aneurysms. Of those 78 that developed the aneurysms, he's looked at the patients who were continued on DAF versus an aspirin monotherapy, didn't really find much of a difference. Of course, you can argue this is a patient with 78 studies, and we're not looking at the thousands of patients where we're seeing marginal differences, but no real gross mass difference there. Hitting into the big topic, anticoagulation, when to do it, what to start. There's several studies out there, small in scale. Doi et al. Examined 51 patients over 49 months. Of those, 19 were treated with warfarin. Of those patients that had a therapeutic index, therapeutic range greater than 60% of the time, were observed in 8 patients, and those had no observed events, as opposed to the group where they either were not prescribed anticoagulation or they were under that 60% benchmark. They had 33% of those, 14 out of 43 of those invented or had some factor of a major adverse coronary event. In our pediatric population, kind of a landmark trial for them to escalating therapy, Sugara et al. Describes 68 pediatric patients with giant aneurysms. 19 of these patients were treated with warfarin plus aspirin. Only one of those had a non-fatal MI, versus 49 of those patients were treated with just aspirin alone. 16 out of 49 of those developing an MI with 7 deaths. And then Suda et al., to kind of further compound on that, followed 83 patients treated with warfarin over 10 years. 91% of those had remained event-free at that point. 2.9% incidence rate per follow-up year. And balancing that with the patient who were treated with warfarin. Now, granted, this is a pediatric population, so both of these markers will probably be elevated in an adult population, but 1.7% of these developing hemorrhagic complications. So the guidelines kind of conclude for the pediatric Kawasaki guidelines. It's a class 2A, level B evidence, starting anticoagulation on these patients prophylactically with larger giant aneurysms, and that's greater than 8 millimeters size. Not indicated given the bleeding risk with smaller, medium-sized vessels. And direct oral anticoagulants, there's no studies really on this, just case reports. Pediatrics don't really use the DOAC since they're not studied. There's not really any studies looking at coronary thrombus prophylaxis or therapy for that matter in aneurysms. Kind of a nice summary slide here. Really showing a lot of red in that there's not really class 1 indications for a lot of these therapies. What about non-invasive ischemic testing? If you've been wondering when I was going to bring that up, and if thought I may be dodging it, and that's because there's not really a lot of evidence support one non-invasive ischemic test over the other. Consensus is that when you do testing, it should include at least some kind of definition of the coronary anatomy. In other words, treadmill stress test alone is not sufficient enough to really test these people. Generally, inconsistent findings on their perfusion studies. This is kind of playing into that. Are we dealing with more macrovascular or microvascular disease? What is the true prevalence, as well as like what is the severity that the role is playing here of the aneurysm? And it never really guides truly intervention. Partially that is because these interventions are very difficult. So it has to be a pretty dramatic presentation to convince an interventionist or a surgeon to intervene on these. The Kawasaki guidelines state that periodic testing should be considered in an aneurysm patient. Once again, they're dealing with a pediatric population, so a little bit more vigilant. In adults, there's no guidelines to suggest this, but typically how these patients are worked up is that they're coming in with symptoms that we believe possibly are contributing, that we should test them with some kind of test to define our coronary anatomy. and that test should be supplemented. Not really, hang your hat on just one test in particular, but should be supplemented with your invasive, whether you're doing FFR, IVUS, or non-invasive functional testing, if you're doing myocardial perfusion or scan or something like that. So jumping into, you've decided now that you've seen this coronary aneurysm, you're saying it's playing a role in the patient's symptoms, you get the interventionist to agree to intervene on it. Only real case reports pertaining to asymptomatic patients with coronary aneurysms, these incidentally found. Most of the studies looking at outcomes, once again, almost all these studies are pertaining to patients that are presenting with ACS or worsening angina. There's also, as Dr. Nicholson was talking with him, there's no FDA-approved equipment for the treatment of these aneurysms. So these are more for humanitarian reasons that you'd be treating this off-label. And given the variety of anatomy in these aneurysm vessels, there's really no one-size-fits-all in the intervention that can be performed. Each one has to be tailored and individualized, and you need a very skilled operator. And if the segment is too long, you run the risk of stem malposition, which can have pretty severe consequences. Kawasara et al. Provided a very nice chart highlighting the trials in which intervention was performed. Not to dig too deep and put you guys to sleep with every single trial that was performed here, but trying to highlight here with the red circles, in that these patients, although small in number, are showing higher incidence of major adverse cardiovascular events, ranging the 15 up to 44% range when they had PCI performed. That's mainly driven by non-fatal MIs, sudden cardiac death, need for repeat PCI or bypass, in-stent restenosis, particularly with these covered stents, and very high no reflow at timing intervention. But if you're going forward with it, there's several factors to consider. The emphasis, of course, is to restore blood flow in obstructive disease. Typically, that's complicated by a very high thrombus burden, heavy calcification. So augmenting your therapies with thrombectomy, glycoprotein 2B3A inhibitors, the shape of the vessel, the length of the disease component, what landing targets both at the beginning and the end of the vessel. Dr. Nicholson gave a kind of a focus in that when he's dealing with it and he's intervening on it, he's more so focused on where is he landing that stent in the beginning and the end, less of what's going on in the middle. Here's a case that we had presented earlier, a video showing that pseudoaneurysm from a post-PCI complication. They open that area up, they see that pseudoaneurysm, they deploy a graft master there, and the pseudoaneurysm disappears with a covered stent occlusion method. Several different covered stents out there. Stent coil embolization is a nice figure from neurointerventional surgery paper. With the basic premise that you're sticking a microcatheter up there, jailing that area, giving it support with either a stent or a balloon, and filling that area up with a coil, prevent thrombus formation, kind of block that area off. Here's a case of that. We're seeing this, and they're using the balloon method here. They're filling that up with a coil, blocking that area off. Nice result there. Dr. Douglas's case, back to his very interesting intervention on the SVG aneurysm. We're seeing that aneurysm here, bleeding into that area. We know that area below that area is just filled with thrombus. Using the angiography, using CT to kind of get the metrics of that aneurysm formation, getting the sizing of it, and then putting an occluder device. Those wires are occluding a little bit, but if you can see, the occluder device is completely now blocked off an aneurysm with a successful implantar duct occluder. Our surgical interventions, there's limited data on this to say which one may be better than the other one. Slightly better suggestions with Kawasaki patients. The ideal intervention, of course, not being really studied. And even asking some of our best surgeons here, I was talking with Dr. Guyton about this, and he says that he's actually intervened on very few of these. You can count them on his hand. and primarily the main methods being aneurysm ligation, resection, marsupialization with interposition graft. That's where they kind of fold the vessel out on itself, suture it down, they put a graft over it. The most common method being, though, opening that aneurysm up, suturing its proximal and distal ends together with subsequent bypass grafting, which is the most common. And with that, I thought Kawasara posted a beautiful slide on what I hopefully didn't waste your time explaining. Just kind of the overall, the mechanisms that can have it are multifactorial, the phenotypes, the different shapes we might see, presentations, and there are various presentations that they can show, as well as what to consider, primarily being with anticoagulation, whether you're doing a single platelet, dual platelet, or escalating them to more warfarin or a DOAC. And then what are our options if you do want to have an intervention? Just want to say special thanks to my wife. She's now the most knowledgeable OBGYN in Atlanta. Also taking care of our puppy so I can work on this project. Dr. Jokadar, amazing fund of knowledge, mentorship on this project that was extremely helpful. Dr. Douglas, Dr. Nicholson, all their interventional wisdom, their cases. My amazing co-fellows, special thanks to Pratik, Maya, Ayman, Bruno, Ahmed, Attila, who really helped me find these cases and build this presentation. And of course, all the Emory cardiology faculty wouldn't be sitting here without you guys, and especially the ones where I was kind of running these clinical scenarios on what would you do with these kind of cases. With that, I'll open it up to questions. Thank you again.
Thank you, Errol. It was very good. Excellent review. Yeah, I don't have a lot of questions. I agree. I mean, my experience, although somewhat, limited just in terms of the medical management, right, is that I have a couple of patients with very large aneurysms, and warfarin has just been sort of the key in my experience. And it's interesting, actually, the two of them that I have also have hypertrophic cardiomyopathy, so they're not on. They had difficulty tolerating nitrates. I thought it was due to hypertrophic cardiomyopathy, not necessarily. So, but it might have been causing problems with their actual coronary flow as well. Now that you mentioned, I didn't realize that non-hypertrophic cardiomyopathy patients with coronary aneurysms might have difficulty tolerating nitrates.
Yeah, no, it's an interesting point. And like I said, there's a lot of cases where we've seen these giant aneurysms and they did get some kind of nitrate therapy and they saw benefit from it. But yeah, I found that really interesting too, because that's kind of the thing we always first and foremost start them on some kind of nitrate therapy.
Errol, this is Mon.
Hey.
Great job. The nitrate situation is fascinating. I have one patient who has had cardiac arrest with nitrate. He's a Kawasaki coronary aneurysm patient, incredibly sensitive, and he described several episodes where his pleads for someone not to give him nitro when he comes in were ignored for chest pain, and he was given nitro, and next thing they're doing CPR. And I also have patients who I have on long-acting nitrates for angina, stable angina. So it's an interesting situation. We have a vacuum of data, but no paucity of strong opinions.
Yeah.
So I think everyone, as you exactly said, has to be treated individually, whether it's with revascularization or some form of antiplatelet anticoagulation mix. We have some guidelines to help us, mostly pediatric based, and this nitro situation is quite fascinating, and I don't have a clear explanation, except maybe that if you drop, if your flow is so sluggish in the coronaries at baseline, and then you drop your preload, next thing you know you're in PEA. That's, for lack of a better, more sophisticated explanation, that's sort of my thinking process on this. But I'd be curious if anyone else has thoughts on this.
Oh, great job, Andy Smith. Could you just comment? So these things occur in the coronary arteries, but are not really highly associated with other vascular beds with aneurysms. Any thoughts as to why that might be, and also any comments about management of aneurysms and other vessels, and whether anything we do in the coronaries applies to that. So that's just one question. The other thing is, I was intrigued when you talked about how obstruction might result in aneurysm formation, and I thought that the work, and I don't know if anybody in Dr. Taylor's lab is on the call, but the work that he does related to how patients with amputations in third world countries from where there are landmines develop aortic aneurysms due to abnormal flow patterns, and how abnormal flow can lead to aneurysm formation. So just two comments and questions there.
Yeah, thank you, Dr. Smith. So in relation to aneurysms throughout the rest of that, there have been associations that I don't know if you remember that very first case with that mural thrombus from the 1953 patient had passed away from a LAD aneurysm. They also found several other aneurysms within him. He had a large abdominal aortic aneurysm, believed to be due more of an atherosclerotic subtype. And there are, it's tough to, and this is kind of where you get pinned down into what is the etiology of that aneurysm in that specific patient. The patients who have a more genetic predisposition, whether that's some kind of syndrome, connective tissue disease, or just some kind of genetic predisposition to developing these kind of coronary aneurysms, can also leak over into aneurysms intracranial, abdominal, aortic, or other vasculature aneurysms. Where it kind of relates to our treatment there, I think the one factor that maybe separates the coronary aneurysms from the rest of these aneurysms is obstructive disease, and that it's a lot more dramatic presentation when we have coronary obstruction, whether that's by a thrombus, I guess the only other relation thinking about it, maybe if they have had a stroke or something like that, in which case those patients with intracranial aneurysms are treated similarly pretty aggressively with anticoagulation, things of that nature. That's a really interesting point in the hemodynamics and how these affect these aneurysms. And that's what a lot of these studies really focused on, is you have this aneurysm, you have this pre-stenotic lesion, this post-stenotic lesion, and that blood in that aneurysm, you have to imagine, is just swirling in there and causing stress at certain focal points. And the thought is that maybe they have multiple factors: genetic predisposition, any patient getting amputation, or patients with atherosclerotic disease are going to be more prone to having vessel weakness to begin with. And is that the hemodynamics playing a factor in that? And I think that's absolutely implicated, but I don't think that there's been sufficient proof. But yeah, two great points.
Errol.
Thank you. But I guess when you see a coronary aneurysm, you don't generally go looking for other aneurysms. Is that correct? There's no recommendation to do any other type of screening.
Right. I don't know. I know Dr. Jokinar can maybe speak to some of the pediatric population. Generally in the adults, no. Besides just guideline screening, if they've been a smoker for their entire lives, you're going to check them for abdominal aortic aneurysms. But in general, unless you can maybe find some sort of pathologic condition associated with it, particularly if they're younger and they just have isolated aneurysms, I don't think that there's guidelines to really look into other aneurysm formation, but I don't think that you'd be faulted if you did.
My sense is that if you suspect FMD, you should go looking for other FMD, and Brian Wells is our expert in this area. But obviously, if you're dealing with polyarteritis nodosa type symptoms or Takayasu type symptoms, then you got to go there. But if just isolated coronary aneurysms, it looks like Kawasaki, I'm not aware of any recommendation to go looking for other things.
Thanks, Sure.
Errol, quick question from Dr. Sherman, who typed it in, asking about anticoagulation for these patients recommendations after stent. I assuming he's meaning patients that also have to be on warfarin, like they have giant aneurysms, and say they get some sort of intervention.
Yeah, the question of triple therapy.
Exactly.
Yeah, look, and this is a scenario, and I really appreciate everyone who gave me these cases, and I can tell you that of the cases that I have looked at, almost every single case has been treated differently, and that question did arise sometimes. I'll use Dr. Jopadar's name with again, and what I think how I would treat these patients based on what I've seen is similar to how we treat other patients that require long-term anticoagulation, and that it may be, if they can tolerate it, triple therapy for a short period as a month, and then maybe stepping down that therapy to reduce their bleeding risk. So if they had a stent, they have a need for that anticoagulation because you've isolated this very large aneurysm. So specifically, if you think it's contributing, stepping them down to maybe after a month from triple therapy to more of a Plavix, warfarin. After a year, if the Plavix is not really indicated, maybe stepping them down from aspirin to warfarin, which is the more common route that is taken both in the literature and within our own internal cases. Great question.
Well,
Hey, Errol, it's Brian Wells.
Hi.
Great job on your talk. I heard you mention FMD, and I agree. I think the point was made that it's very unusual to see coronary artery aneurysms as a manifestation of FMD, and we don't know why that is, because you see this typical beating pattern in the carotid and the renal arteries, and we tend to not see that in the coronary arteries. So on the other hand, we see the tortuosity and dissections and things, but it's unusual to see coronary artery aneurysms in FMD patients specifically. Did you come across anything else with relation to that?
No, I mean, I found case reports really describing coronary aneurysms isolated by itself without some other kind of FMD type syndrome. I didn't come across that in my literature review.
all right. Well, Errol, again, great presentation. Thanks for the review and the interesting discussion. And thank you, everyone, for tuning in today. And we'll see you next week.
The preceding program is copyrighted by Emory University.